Good morning, everybody. I'm Mukesh Harisinghani from the Mass General Hospital in Boston, and I'm going to be talking to you today about the use of MR in imaging of the bladder and the female urethra. We're going to cover a little bit about the anatomy in these specific anatomic areas, talk a little bit about the MR technique on how best to image the bladder and urethra, and then discuss the clinical utility of MR in those conditions where MR really is useful in providing clinical information to our colleagues for making appropriate decisions for treatment. And so when we talk about urinary bladder, the urinary bladder is the most distal conduit which receives the urine from the ureters. And if you look at the sagittal image of a male pelvis, you can see that the dome of the bladder is lined by peritoneum, but the bulk of the bladder is essentially extraperitoneal. And you can see this anatomic fact in the sagittal reformatted CT image, where a CT cystogram has been performed and there is an intraperitoneal leak that is leaking into the peritoneal space overlying the bladder. As regards the bladder wall, if one looks at histopathology, it essentially is comprised of the following layers. The lumen is lined by urothelium, which is primarily transitional cells. Underlying the urothelium, we have the lamina propria and the submucosa, and then underlying the inner layer, we have the detrusor smooth muscle. The detrusor muscle is an involuntary muscle, and that's the most important anatomic structure that we need to pay attention to when one is assessing the bladder by way of MR. And so if you translate this anatomy into MR, the typical normal bladder wall thickness varies between 2 to 8 millimeters, as is seen in the sagittal images of these two different patients. This patient also has a bladder diverticulum that we'll be talking about in a little bit, but typically the normal wall thickness is somewhere between 2 and 8 millimeters. If you look at the T1 weighted images, and here is an example of a T1 non-fat saturated image, and this is a T1 fat saturated image. So the urine clearly will be dark on T1 weighted sequences, and the muscle, which is better appreciated on the fat saturated images, has similar signal intensity as a skeletal muscle in the pelvis. So that's what it looks like on T1. On T2 weighted images, the urine is bright, and there is a stark contrast between the urine and the bladder wall, which essentially is comprised of the detrusor muscle as we see on MR. There are times when on MR you can see two distinct layers. So in this particular case, you can actually see a inner compact layer, which is a little bit darker compared to the larger, thicker part, which is less dark. And here is a low B value diffusion weighted image, which is similar to a T2 weighted image, showing that the banding of the muscle layer a little bit better, where you can see that there is an inner darker layer that is seen adjoining the lumen, whereas the outside is a little bit brighter. So you can appreciate these two bands, but you may not appreciate it. So that's something to keep in mind as well. As regards the technique, we used conventional phased array coils. We scan with slice thickness of between 3 and 4 millimeters. You want to be as thin as possible. With a reasonable matrix size to give you good quality images. Now, as regards to bladder distension, what you don't want in MR is something like this, where the bladder is totally collapsed, because you can falsely call thickening of the bladder wall, or you don't want somebody to have the bladder fully distended like this, because that leads to thinning of the bladder wall, and also the patient has discomfort that can lead to motion artifacts. So what do? You ask the patient to avoid typically about 1.5 to 2 hours prior to the exam, and that leads to adequate bladder distension. The other important point before starting the MR is to assess the history, and if the patient has had any kind of surgical intervention. So for instance, if the patient had a transurethral resection of bladder tumor, you have to wait for 2 weeks because you want the hemorrhage and the changes from the procedure to have resolved. If the patient has had a office cystoscopy, you have to wait for 2 to 3 days because you can have air that is present in the lumen of the bladder that can lead to susceptibility artifacts on the diffusion-weighted MR. So waiting for a few days will clear the air and enable good quality assessment of the bladder. Now let's look at how you would image in terms of the protocol. You start with a triplane localizer, which essentially is a very fast gradient echo sequence, and this allows the technologist to assess the extent of the bladder. Typically, you want to be scanning from the level of the pelvic inlet, which is about the inferior margin of 1.5 centimeters to below the inferior margin of the pubic symphysis, to up to the level of the aortic bifurcation. After we do the localizer, we do a large field of view T2, and the goal is to try and look at the kidneys, because many times disease entities that affect the bladder wall can cause secondary hydronephrosis, and this is a quick look to assess for presence or absence of hydronephrosis. One word of caution: when you use these quick, relatively motion-free T2 weighted sequence, the haste or the single shot fast spin echoes are extremely susceptible to fluid motion. So as you can see in the bladder, any kind of motion of urine leads to signal voids. Sometimes the signal void can appear and masquerade as a mass, so you have to be extremely careful that you cross-correlate on the actual axial fast spin echo T2. In this case, there's nothing there. This is merely an artifact that is arising from the flow of urine. So just be careful when you use these large field of views. Do not end up mistaking this flow voids for intraluminal lesions. After we do the large field of view T2, we do triplane conventional fast spin echo or turbo spin echo T2s, and these are essentially the money sequences along with the diffusion and gadolinium enhanced images. So we acquire the T2s in axial, coronal, and sagittal plane, again covering pelvic sidewall to pelvic sidewall, ensuring that you have adequate coverage of the bladder. After we do the triplane T2, we acquire DWI, and the diffusions are acquired with a low B value, an intermediate B value, and a high B value of 800. It's important to pay attention to image quality, and one way of ensuring that you have good quality images is to vary the necks or number of excitations, especially for the high B value, where because of relative lack of signal, you want the necks to be high so that you can actually nicely see the outline of the bladder wall. And then from those low and high B values, you get an ADC map that is generated. After we do the DWI, we do the gadolinium enhanced images, and it's typically done as a non-contrast quick run followed by dynamic images where you start at 30 seconds and then can scan for 3 to 4 runs following that, and then do a delayed high resolution image. It's also important to get subtractions once you give the contrast. A word of caution about the plane of acquisition of the dynamics. Now, if the tumor in the bladder is present in the dome or the superior or the inferior wall, you can acquire the images in sagittal. But as is seen in this case, you can see that there is a tumor arising from the inferior wall, and the sagittal dynamics will suffice. But if the tumor affects the right or left lateral wall of the bladder, then you either need to acquire the images in coronal or axial. So there is a lesion seen in the right lateral wall. So if you acquire the sagittal image, you are not going to be able to assess the relationship of the tumor to the bladder wall. So you have to acquire the dynamics either in the coronal or in the axial plane. So that's something important to keep in mind when one is doing the dynamic enhanced images. So that was the protocol. Now the question is, where is bladder MR most useful? And the one condition that we are called upon to use bladder MR routinely is for assessment of bladder cancers. So typically, the way these patients present, they have frank hematuria, and there is a high clinical index of suspicion for bladder cancer. These patients undergo clinical investigation. They undergo an office cystoscopy, and following the biopsy, they have diagnosis of bladder cancer, and then they have to be staged. And primary for staging, you use the transurethral resection of the bladder tumor along with radiologic staging. So that's sort of in a nutshell how the bladder cancer patients are sort of worked up. Most bladder cancers are urothelial cell carcinomas, and they can be divided into two. We have the low-grade papillary lesion or the high-grade papillary lesion. The high-grade papillary lesion can be divided into those that have no muscle invasion and those that have muscle invasion. So here is an example on a cystoscopic view of a papillary lesion within the bladder, and this is what normal urothelium looks like. And if it gets if there is a tumor arising, it projects into the lumen from this urothelial surface. So this is what it looks like on cystoscopy. Now, why is it important to know the distinction between the high and low grade and muscle invasive versus non-muscle invasive? Because the muscle invasive cancers typically have bad prognosis, have aggressive growth, and also lead to nodal metastases. Now, as I mentioned earlier, the primary diagnostic tool for diagnosing and staging bladder cancer is the transurethral resection of bladder tumor. So they do an office cystoscopy either with or without anesthesia, and then they resect the bladder cancer, and the goal is to try and get enough of the wall so that you can say with high level of confidence that there is muscle invasion. And if there is muscle invasion, these patients typically go for cystectomy and adjuvant therapy. The two key points here are they need to have done a proper TURBT for getting adequate sampling so that they can make the correct diagnosis of muscle invasion versus not. The problem is that depending on how experienced the person performing the cystoscopy is and how well the TURBT is performed, it can understage the tumors in about 25% of cases. So imagine if this lesion is just resected superficially and not adequate sample of the bladder wall is taken, then it is very difficult to know if there is muscle invasion or not. Hence, MR is a very useful complement for TURBT and can provide useful information in terms of assessing muscle invasion versus not. And so if you look at a schematic of the bladder cancer, T1 tumor is essentially a tumor that is confined to the mucosa and submucosa. T2 is when the tumor extends into the bladder wall or the muscle. And T2 disease basically is muscle invasive. And depending on whether it's the inner half involvement versus extending the entire width of the muscle layer, it is divided into T2A and T2B. And so the goal for us in MR is to distinguish the superficial cancers from those that are invading into the muscle, because as I mentioned earlier, if you have muscle invasion, then these patients typically need to get cystectomy along with adjuvant therapy. And then T3 lesion is when there is tumor extension beyond the muscle through the perivesical fat, and T4 is when it involves adjacent pelvic organs. So how does MR help? It helps by reducing staging error. So it's a good complement to the TURBT technique for assessing muscle invasion because we are able to better visualize the anatomical structures of the bladder wall, and we are better able to differentiate T1 from T2. The other uses of MR clearly are in the setting of post-treatment. So once patient has undergone therapy, and then also in terms of looking at the bladder diverticulum and tumors within the diverticulum, because these can be blind spots for the urologist. And I'll show you examples of how that is done. Now, if you look at the literature, there has been a recent spate of articles looking at YRADS, which is basically a reporting schema that similar to PIRADS in prostate cancer and BIRADS in breast cancer has been proposed for accurate assessment of the bladder cancers. And it uses T2 weighted images, dynamic contrast enhanced images, and DWI to make the assessment. The bottom line is with this particular schema is that you are trying to detect presence or absence of muscle invasion. So I'm going to try and simplify the scheme and give you the salient points that are pertinent for you to mention in your report to assess whether there is muscle invasion or not. Before we begin on that, it's important to keep certain things in mind. The first thing is make sure that you use all sequences. And so unlike prostate, where you have the concept of dominant sequence, whether it's tumor is arising in the peripheral or the transition zone. In bladder cancer, you have to make sure that you pay attention to all the three sequences, that is the T2, the DWI, and the DCE enhanced images. And the second thing is you're looking for a stalk. So in terms of looking at all the sequences, why is that important? Because if you look at the various structures in the wall of the bladder, different sequences provide different information. So that's one reason why you need to make sure you look at all the sequences. So here is an example of a patient who has frank hematuria, and a bladder MR has been performed. So you can see on the T2-aided sequence the outline of the bladder wall. And it's not very easy to spot the tumor on this. If you look at the high B value, you can clearly see there is a polypoidal lesion arising from the right lateral wall, which has a stalk. And post-gadolinium, against the backdrop of opacified urine that is appearing bright on the T1 weighted image, you can nicely see the frond-like projection. So just to kind of enlarge the two images, you can see the nice stalk. So this is why it's important to pay attention to all the sequences in terms of detection and accurate staging. And here is another example where the patient has a little bit of hydronephrosis on the left compared to the right. As you can see, there is dilatation of the urethra on the T2 weighted sequence. Patient did have frank hematuria. On the high B value, you can see that there is restricted diffusion along the wall and extending into the distal ureteric orifice. And on the early dynamic enhanced images, you can see that the lesion is enhancing. And this was biopsy proven to be a transitional cell carcinoma with extension into the urethra as well. So look at all the sequences. Now the second thing is to look for a stalk. Now having a stalk is a good sign. So the stalk is made up of loose sort of connective tissue. Here is a papillary lesion projecting into the lumen, and you can see the stalk on the histopathologic analysis. So the stalk connects the cancer to the bladder wall. So stalk with, if you have a stalk in a bladder cancer with no adjacent bladder wall thickening, that's a good sign, and that indicates that that tumor is not invading the muscle. So let me show you some examples of that. This is a patient who has frank hematuria. On the T2 weighted sequence, you can nicely see the outline of the muscle. And in this instance, you can actually see the dual signal. You can see the inner dark signal and the outer a little bit brighter. So there is a large polypoid lesion arising from the right lateral bladder wall. And again, you can see the stalk as it projects into the into the center of the lesion. Same thing is seen on diffusion. And again, on the enhanced sequences, you can see the outline of the stalk. So having a stalk is a good sign. This tells you that this patient does not have bladder muscle invasion. Here is another example showing, again, the ability of all sequences to provide the information. You can see on T2 weighted sequence, there is a polypoid lesion arising from the left lateral bladder wall. Here is the ureteric orifice coming in, no dilatation. It surrounds the ureteric orifice but doesn't obstruct it. And on the diffusion, you can nicely see the outline of the lesion with the prominent stalk. And again, this indicates likely there is no muscle invasion, which was not seen in this particular instance. So use all the sequences and make sure you look for a stalk, which is considered to be a good sign. So let's look at some examples of the tumor staging. So T1, remember, is superficial cancers with no bladder with no detrusal muscle involvement. So here is in one example, you can see the lesion arising from the right lateral wall. Again, you're seeing a stalk which is present. Now, there has been a study which has been done looking at the T2 signal characteristics of the stalk. Majority of the stalk, about 40%, are dark on T2, but occasionally it can be bright, as is seen in this particular case. It doesn't really make a difference in terms of the ability of the presence of stalk to predict lack of detrusal muscle involvement. So again, pay attention to the stalk, and when it is present, it's likely that the patient does not have detrusal involvement. Here is another example looking at the gadolinium enhanced sequence. You can see there is early enhancement of the lesion and there is preserved bladder muscle. So this is clearly a superficial bladder lesion with no muscle involvement. Here is an example of superficial muscle invasion. So T2 means there is involvement of the detrusor, but it is less than 50% extension into the detrusor muscle. So as you can see in this particular instance, the lesion shows restricted diffusion. It does not have a stalk. and there is thickening of the bladder wall. And so that kind of tells you that there is, likely muscle invasion, and you don't see the tumor signal into the or extending throughout the thickness of the bladder wall. So this is superficial muscle invasion. Here is another example showing the same. You can see that there is enhancement of the early enhancement of the lesion, which extends for less than 50% of the thickened bladder wall. And here is the diffusion in the same patient, showing restricted diffusion with thickening of the adjacent bladder wall, again with no stalk being present. T2B is when the entire thickness of the bladder muscle is or detrusor muscle is involved, and in this case you can see there is a thickening of the bladder wall with the evil gray of the tumor extending the entire length of the bladder wall with maintenance of the normal signal anteriorly. A different patient, again left lateral wall, you can clearly see there is no stalk that is present, and it clearly extends the entire width of the detrusor muscle. Another example of complete extension, polypoid lesion in the right lateral wall of the bladder. No presence of, there is no stalk that is present, and again you can see the gray signal intensity matching that of the tumor extending the entire length. On the enhanced images, you can see the extension of the enhancement throughout the the thickness of the wall. And on the high B value, you can see the tumor. And when you superimpose the high B value on the T2, you will see that there is extension throughout the wall of the detrusor muscle. And T3B is when there is extension into the perivesical fat. Again, this is easy to kind of delineate. You can see that there is a tumor nodule extending from the bladder wall into the fat. A different patient, a bulky cancer extending into the adjacent perivesical fat, and then finally looking at extension into the pelvic side wall, which is T4B. In this case, you can see there is normal muscle on the left side, and on coronal weighted images, you can see that there is tumor extension into the muscle and pelvic side wall. So this is T4B. One other useful attribute of MR is the ability to detect multifocal disease in the bladder. And so in this instance, you can see that there is a large primary lesion which is causing obstruction to the urethra with a smaller lesion present in the distal urethra. The lesion is showing marked restricted diffusion. And in addition, when you look at the other sort of slices, you will see smaller lesions that are present within the bladder, again appreciated on the high B value, showing restricted diffusion. So this again alters the way the patient is managed. Nodal disease. Bladder is one of those tumor subtypes in the pelvis that can cause enlarged lymph nodes as a result of tumor metastases. So in this instance, you're seeing external iliac nodes that are enlarged, showing restricted diffusion. And when you do see them enlarged in size more than 8 millimeters in short axis, you need to call attention to these lymph nodes. Now, in terms of cancer arising in a diverticulum, this is an area which is of particular importance, where MR can be a very useful tool for the urologist. The reason is these bladder diverticuli can have a very narrow neck. So here is one example where the patient has a bladder diverticulum, and as you can see, the neck is very narrow. This bladder diverticulum was totally missed by the urologist because they were unable to spot the opening. And so that's important to keep in mind in terms of detecting tumors that arise in the bladder, bladder diverticuli. The other fact that is important to keep in mind is that bladder diverticuli typically they lack the detrusor muscle. So by virtue of having a cancer within a diverticulum, it is assumed to be muscle invasive because there is no detrusor muscle that is present in the diverticulum, and that's why also it is important for us to find these cancers and show the cause of hematuria. So this is one patient where the patient had frank hematuria, had 2 office cystoscopies which were negative, again because of a very narrow bladder neck. As you can see that there is a posterior bladder diverticulum with a large cancer arising within the diverticulum that enhances early on. So again, a useful technique for urologists to find the cancer and appropriately then treat it. This is again a very large posterior diverticulum with a tumor arising in the left lateral bladder wall, showing early enhancement and marked restricted diffusion on the high B value images. One useful use of MR is to look for tumor response assessment. So typically when they have bladder diverticuli, these patients get chemoradiation, and this is one such patient where pre-treatment you can see there is a large cancer in the posterior diverticulum that enhances early on, and after therapy the tumor has dramatically shrunk. So useful way of following these patients. So that's sort of in a nutshell how MR can be useful in the assessment of bladder tumors. Shifting gears to now looking at the female urethra. Although the female urethra is relatively short compared to the male urethra, there are certain specific disease entities that affect the female urethra, and which are relatively easy to make the diagnosis by MR, and hence the role of MR has taken on a key key role in terms of diagnosing these conditions. So this is what a normal female urethra looks like on a T2 weighted sequence. The primary sequences that you use for a female urethral assessment is similar to that of the bladder. Instead of including the entire bladder, you sort of bring down the FOV lower to be centered in the urethra. So again, the primary sequences are T2 weighted sequence. So here is an axial and this is a sagittal image. And so there are sort of two rings that we see. We have the inner bright ring that represents urine or secretions within the lumen. Then we have an outer dark ring, which is, this represents the inner mucosal layer representing epithelial cells. Beyond that, we have a bright ring, right, as you can see on this axial image, that represents the submucosal layer with enhancing vascularized connective tissue. And then beyond that, we have a low signal intensity rim, that is the outer muscle layer representing smooth muscle. So it's important to identify these four rings on the axial and sagittal images, T2 weighted images, when you are imaging the female urethral region. So the common condition that we can diagnose very easily with MR in this particular region is a female urethral diverticulum. This typically arises because of inflammation of periurethral glands. These glands get obstructed, they can lead to abscesses, and then rupture of this abscess into the urethra is what ultimately leads to the formation of a diverticulum. It's typically seen in younger patients, and patients usually present with dysuria, urgency, or incontinence. And this is the typical appearance. As you can see on the axial image, you have this curvy linear horseshoe-shaped T2 bright diverticulum surrounding the urethra, which is in the center right here. On coronal, it looks like a prostatic tissue, but it's very bright on T2. You can see here is a urethra, and it surrounds the urethra bilaterally. Again, seen on a little bit anterior location in the coronal T2, and then on the axial gadolinium enhanced image, you can see that area of the diverticulum is relatively devoid of enhancement, has a little bit of enhancement along the wall owing to inflammation, and this is the enhancing urethra in the center. So that's the appearance. Now, you can have complications. Sometimes long-standing diverticuli can have fluid level, as you're seeing in this case, and this can be a result of prior infections or hemorrhage. In this instance, the urethra is a little bit eccentric, and the diverticulum is predominantly left-sided, and you can see there is a fluid level on the axial T2 weighted sequence. On the gadolinium enhanced images, it again shows the classic non-enhancement of the diverticulum. Occasionally, you can get stone formation. So in this sagittal T2 weighted sequence, and on these axial images, you can see layering stones within a diverticuli. Here is the urethra again situated a little bit eccentrically. And this is the same patient on coronal showing the multiple diverticuli within this enlarged periurethral diverticulum. Long-standing inflammation and long-standing diverticuli can entice multiple bouts of inflammation, which may, progress to tumor formation. So urethral carcinomas are rare. They are usually squamous subtype in terms of histology. And this is what they look like. So as you can see, underlying the bladder in the vicinity of the urethra, you have an ill-defined mass. Compared to what I showed you early on in a diverticula, in this instance, there is soft tissue density that is present in the location surrounding the urethra and clearly shows enhancement, unlike what you saw with the diverticuli. So this is what a tumor looks like. If it gets bulky, this is what it turns into. This almost looks like a prostate, but this is a female patient. Again, there's a large tumor that encircles the urethra, showing marked restricted diffusion and again showing varying levels of enhancement and necrosis. So that is what a squamous cell carcinoma looks like. One other important point to keep in mind is occasionally in patients who have undergone pelvic surgery as well as peritoneal resection for ovarian cancer, the retropubic periurethral location is a common area to look and also to find metastatic tumor deposits. So in this instance, you can see on the CT image, there is a enhancing nodule seen posterior to the pubic symphysis, which on the T2 weighted has the sort of the gray signal intensity and showing heterogeneous enhancement. And this was biopsy proven to be ovarian cancer metastases in a patient who had undergone prior surgery. So the last point is there is one specific intervention that you need to be aware of in the female urethral region, which can have a imaging appearance that mimics the periurethral diverticulum. And so before you call something a periurethral diverticulum, it is very important to look into the patient's charts and make sure that they have not undergone a periurethral bulking agent installation. This is done to treat stress incontinence. Typically, the common agent that is used is collagen. There can be other inert substances that can be used. And as I mentioned, based on the location where these are instilled, they can mimic periurethral pathology, specifically a diverticulum. So again, if you have something that looks like a diverticulum, always look in the patient charts to make sure that the patient has not had a periurethral bulking agent installation. So this is what it looks like on CT. Now remember, collagen is an inert substance. It should not show any enhancement and be relatively low in density on CT. So in this instance, you can see the patient has bladder wall thickening, probably from long-standing urinary issues. And here is the low density area surrounding the urethra on the coronal and on the axial image. Again, looking just like a urethral diverticulum, but it's not. This is collagen that has been instilled adjacent to the urethral location. On MR, it will have a similar appearance. If it is acute, collagen is going to have a high water content, so it's going to be very bright or hyper intense on T2 and will not show any enhancement. If it's been instilled and there has been a significant time that has elapsed since the installation, it can be iso or hypo intense with time, but the key is it does not show any enhancement. So this is what it looks like on MR. As you can see that there is, again, the semilunar sort of area of intermediate signal surrounding the urethra. So this patient has had the procedure performed a few months ago. So it's not an acute installation. But the key is, again, like you see here, there is no enhancement. If I just showed you this image, your first knee-jerk response would be to call this a periurethral diverticulum because it looks just like that. But again, the history is relevant here, and also the appearance on the T2 weighted sequence kind of helps you sway your diagnosis towards the periurethral bulking agent installation. And then lastly, I'm going to show you this case. This is a patient who presented with hematuria, and as you can see on the axial T2 weighted sequence, looks like a very bulky lesion that is arising from the right lateral bladder wall. But pay attention to this structure right here, which is a linear dark line, and that will become relevant. And you can see as you go down, it looks very bulky. And looking at the enhanced images, it shows the same. There is a little bit of peripheral enhancement, what looks like central area of relative lack of enhancement. And so this was thought to be an aggressive looking cancer. They did a cystoscopy, and on cystoscopy, all they could find were bladder clots. The bladder was irrigated, reassessed And again, no lesion was found. Chronic inflammatory, granulomatous inflammatory cells were obtained from the biopsy specimens that were taken. So what is this? This is a severe reaction to a patient who had undergone a procedure where the patient had a vaginal mesh placed along with a sling procedure performed for incontinence. And so the mesh can erode into the bladder. So this is what the sling looks like. As you can see that there is a retropubic sling, and that was the linear line that you were seeing on the axial T2-weighted image. The mesh is not visible on MR, unfortunately, but by virtue of where it is placed, it can erode into the bladder and cause a severe granulomatous reaction. So again, knowing the history, looking at the images can help you sway the diagnosis in the right direction, as was seen in this particular instance, or not called. So you have to sort of keep in mind the findings of these pelvic augmentation procedures that are performed for incontinence. So I think in conclusion, I have shown you how MR can be a useful tool for problem solving in the bladder and urethral lesions. The role of MR is evolving, but we are increasingly seeing more and more volume in terms of assessing these two areas because they're relative blind spots, and MR is a useful complement to what the urologist looks for in terms of information to guide therapy. And as MR sequences get faster and higher in resolution, it probably will become the primary modality of choice for imaging this particular region. Thank you.